Ladies and gentlemen, please welcome back to the stage, Gary Fazio.
Thank you. All right, we're going to keep the show on the road. Hope you're enjoying your meal. I know you have a few bites left, but the best part of the dinner is coming up next, and that wouldn't be me. But without you, this event and the progress we've made would not be the success we're having today. So tonight, we want to focus on actually why we're kind of gathered here, to find new ways to treat and eventually to fulfill what Roger's dream is, to find a cure for pancreatic cancer. This year, for the first time, pancreatic cancer will eclipse breast cancer as the third leading cause of cancer-related death in the United States. If you remember last year, Dr. von Hoff talked about we're fourth, third. Unfortunately, in a few years, the way it's going, the most aggressive disease is projected to pass colon cancer and become second only to lung cancer as the leading cause of cancer deaths. So while other cancers have seen advancements in treatment, progress towards better treatment for pancreatic cancer until recently was at a virtual standstill. What progress there has been is attributable in no small part to our keynote speaker tonight. He is, and listen to this list, he is TGen's Distinguished Professor and Physician-in-Chief. He's a Professor of Medicine at the Mayo Clinic. He's the Clinical Professor of Medicine at the University of Arizona. He's the Chief Scientific Officer at U.S. Oncology and at the Virginia G. Piper Cancer Clinical Trials Program at Honor Health. That's the list of this gentleman. Would you please welcome Dr. Daniel von Hoff.
Thank you, Gary, and good evening, ladies and gentlemen. I might start by saying I think we ought to auction off Madison Macbeth's back of this. This is a beautiful, Madison, wherever you are tonight, is beautiful. Takes after Mom and Dad, I guess. That's Roger, I think, in the golf cart, I think. Is that right, Roger? It's really cute. Well, I'd like to call tonight's presentation Pursuing the Scar. Pursuing the Scar. Everyone in this room has exactly the same mission, to cure pancreatic cancer, and there are three ways to do it. Have therapy for those people who have it, early detection, as you've heard, and also prevention. I doubt it'll be an apple from the doctor. As Gary just said, it is the fourth leading. This year it'll be the third, and by 2030 it'll be the second leading cause. But actually there's pretty good news here, because breast cancer, prostate cancer, lung cancer, colon cancer have all had their mortalities plummet because people concentrating on trying to do it. It will take 300,000 people's lives in 2016, and the incidence is going up because most of us are aging. You already know that. The most important thing, though, are the individuals who are taken by this disease. Pancreas is hidden in the back. I know some people are here for the first time tonight, so it's pretty hard to see where the pancreas is, but it's in the back here. People don't realize it as we're eating our meal, that the pancreas makes 1,800 cc's, or almost 2 liters of fluid a day to help us digest, and also, of course, has insulin in there. It's a very tough place to detect, and that's why the diagnosis is quite late. This is what it looks like on a CT scan. Here's the liver here, and the tumor here is invading, and you can see how invasive it is into the spine here. And many people with the disease say that it causes a toothache-like pain. The people in this room and this industry and others have organized a special effort, and I want to just emphasize it. We've said it many times, but enough is enough, Roger. If not us, then who? And this is an incredible grassroots accomplishment, kind of a let's do it approach. I can't say this enough. I want to thank you for the sponsorship, the time, the donations, the volunteering, the checks. And I look back every year to see the special bond. People have done crazy things. They've wrapped their cars. They put on Superman suits, or we put them on them. They've taken great risk and personal risk at things, as you can see down here, and a few other things. Sorry about those with an obstructed view. Volunteers. Liz, this is one of my favorite pictures. Carrie. And just incredible devotion. So you really are amazing, but I just want to say one other thing, that when this organization was put together, finally somebody was starting to do something against pancreatic cancer. It was not happening without effort of people in this room. You are amazing. You're amazing. You're amazing. You know, it's like nobody cared for a long time. Now, the strategy we have together for our work together against pancreas cancer is get the best possible science anywhere we can, apply it to patient care as rapidly as possible. Now, I tried to figure a way to get the mattress compressed to put it in the bottle. I couldn't quite do it. But the idea is to get it through the usual bottlenecks, because sometimes it takes 14 years to develop a new therapy. But we got to be quick about it. Now, in the early days of this Golf Classic, this was the science. We said that this is what pancreas cancer looks like when it goes to the liver. All these big nodules that are just causing tremendous amounts of scarring. And actually, there's not very much cancer in there. Just little pockets of cancer with these arrows. The rest of it is all scar. So we started with the scar. And the interesting thing is, when a surgeon today operates on a person, he or she can tell right away whether or not that person has a good prognosis, because if it's very rock hard, that's a bad prognosis. And we want to go back to our roots of pursuing the scar again. The other things that have been learned in the years of this Golf Classic by many investigators, we now know that pancreas cancer takes about 21 to 23 years to grow into something detectable in a person. People think they just had it for 2 years, but it really is 25 years. There's injury. It might be the mumps. It might be pancreatitis. And you get inflammation, and then you get repair, and then you get a scar. But if this repeats itself, then you get cancer. So it's not a bad idea to target the scar, believe it or not, rather than the tumor cells. Everybody looks to target the tumor cells. But what about the scar? In fact, in every study, with your support, targeting the scar, it's been successful. It improved patient survival. The scar right now is a gold mine for progress against the disease. It's this Golf Classic's special, absolutely special, and the horn is emphasizing it's about the scar. Okay? Well, since the scar, which isn't a very attractive scientific term actually, the science has grown. And it's now known as the microenvironment. And you have to imagine that getting a grant, it's much easier to talk about a microenvironment rather than a scar. So we've learned that this scar is very complicated in multiple new ways, and it is actually the thing that supports the growth of the pancreas cancer cells. So microenvironment. But let's step back to the first tournaments and classics as to the original idea of attacking the scar. At that time, we were pretty simplistic. We said, it's hard scar, you can't get the drugs into it, your immune system doesn't get it in, so let's just bust it up, okay? Sledgehammer approach. We found a target in the scar. It was called SPARC, S-P-A-R-C. And the man on the video was one of the other folks that actually found that, Dr. Hidalgo. And there was a chemotherapeutic at that time which attracted to the SPARC. So we actually took that into clinical trial. So our observation, this was 2010, Roger remembers, he came up and said, I think there's something different here. There's a scar around the pancreas cancer, it stops the drugs from getting in. We had to get a way to get therapy in, and we came up with this nanoparticle, albumin-coated paclitaxel, now known as Abraxane, which targeted the scar, and it seemed to be just the right size. This is now known as the Goldilocks effect. So we put it together with the drug that we had had for many years, and we actually finished the clinical trial in 1 year. That's pretty fast, with your support. published this. You might recognize Dr. Hidalgo over here. He was in Spain at the time because we knew that he could help us get it done quickly. And published this in 2011. The remarkable thing with this, and people here who know very much about this disease knows that this marker in the blood called CA19-9 always goes up. This was the first time in history that in every single person the marker went down. And sometimes it normalized. Never seen that before. And this tumor loves glucose, loves to take up sugar. So PET scans are very positive, as you can see here in the lung and the liver. But these normalized. By the way, the brain takes up a lot of glucose, so it's always quite dark, as does your heart. And the other thing that was important on CAT scans of the lung is that these tumor nodules, you could see, went away, and this Swiss cheese liver with all of the scar and all of the tumor cells also went away. And isn't it interesting? Even though it was a lot of scar, it actually went away. It wasn't there forever. Another important clue. This was a complete disappearance. And of course, in medicine, what your trial did is give us the dollars to do the pilot trial, to then say, let's ask the question. And it's hard to imagine, but your work here launched 1,000 ships. Actually, it launched 842, to be exact, because it took a large clinical trial sponsored then by Celgene, who had the faith to go forward. If you can think about this, in 11 countries, 151 different sites. Huge trial that was leveraged by what you donated. And what it showed, as you've heard, was a 59% improvement in 1-year survival. But the thing that really impressed people was for the first time there were 2-year survivorships. It's now used to treat more than 75% of all patients in the entire world. And it's being used earlier in the disease, right after Whipple procedure, take out the pancreas to try to prevent it from coming back. And for the first time now in history, there are 4-year survivors and beyond who have had stage 4 disease. It started here, could never have done it without your support. And what's really remarkable is that there's 37 other ongoing trials in the world against breast cancer, ovarian cancer, head and neck cancer, and many others. This same regimen. So you get something that works in one disease, it'll sometimes work in others. And it was pretty safe. It caused some side effects, as people in the room can tell you here, but it was fairly safe. So we published this in the New England Journal. This trial was positive. It worked in the elderly. It worked in people who were not in very good shape. Published in the New England Journal. And what was remarkable, it got regulatory approval just in a few months in the United States. It got approved by the European Union. And the great miracle was it was approved in the United Kingdom, where they don't want to pay for anything. And it said the superior survival efficacy of nab-paclitaxel gem over gem in the management of metastatic pancreas cancer is associated with a positive cost effectiveness and cost utility. It's amazing they don't talk about the efficacy, they talk about the cost first. But this was a miracle that it got approved there. So the question is now, what can we do to improve on this? And I go back to the science again. And you say, Dan, why does this look like Swiss cheese here? You can see here is because those scars do not let the contrast material in. So you give the contrast material to show the cancer, and again, it's not getting in. So Mike Barrett, because of your contributions, we got him a machine, okay, to actually measure the tumor cells and the stroma. And he published this. And I'll tell you, I put down here, Victor loves it because the Johns Hopkins team was now able to measure additional things because of your donation of this particular machine called a flow cytometry. And he showed that these tumor cells that are in this terrible inflammatory environment can actually have a lot of repair problems. They have trouble repairing their DNA. They're kind of stuck in there and can't repair their DNA. So for example, you can measure every gene along a chromosome. This is chromosome 11. And you can say, uh-oh, this part of this gene is high. This gene with green is normal. This gene is high. And by that, published this really important paper that said DNA repair is a problem. These tumor cells could be susceptible to maybe a drug like cisplatin, which was used to cure many people and still is, obviously, all men with testicular cancer. So the new regimen was born. There's a pilot trial. It's what we could afford of nab-paclitaxel plus gem plus platinum in patients with previously untreated. And again, look at the sponsors who made this happen. We call it the TGen triple in honor of Mr. Larry Hall. And as you know, he passed away, Derek's dad. And we honor Larry. The TGen triple is 3 drugs. We presented this at the American Association for Cancer Research, and I think one of the things I will take to my grave is this picture of Dr. Roger Magwitz standing in the American Association for Cancer Research. Only 26,000 members. Many came by to see it, and there he is. We documented this along with Gail Jameson. And somebody came by to say hi. He thought this was such important work. So Roger and all of us got to see Dr. Wani, who is the inventor of Taxol, which is really what cured women with breast cancer. And of course, this is a form of Taxol. Here in this picture, he's 91 years old, still probably the smartest guy in the entire place, and I think that Roger will treasure this. By the way, we made sure that everybody asked all the questions to Roger rather than us. Did a good job. What about this regimen? Why were we excited about it? Because we had 20 patients at the first analysis. And I can tell you that some people, we were going to do 10, but some people in this room opened their pocketbook, helped some people. And we had 2, some people would say 3, complete disappearance of their tumor. And overall, 75% of people had their tumor shrink. It's very dramatic, 75%. And this is holding up. So this TGen triple really works. But here's the tumor size. See for yourself. There's only 2 people here where it got bigger. Everybody else went down. And this, again, is unheard of in patients with pancreas cancer. Now, I can tell you that when somebody presents with pancreas cancer and they have a bowel obstruction, and this right here is the small bowel. I'm sorry to show you this after dinner. This is totally obstructed here with pancreas cancer, plus there's tumor in the liver. And you can see here the tumor in the liver is gone, and this opened up. Do you realize that no surgeon would ever operate on a person with pancreas cancer where there's obstruction? They just throw up their hands, and you can't blame them. But if you can get them where their bowel is open, it looks a lot different. Not only that, I'll just go forward here. When people have peritoneal metastases, which means this tumor is right on the surface of the abdomen, you can feel it through the umbilicus. It's called a Sister Mary Joseph's node. That's because she was a scrub nurse at the Mayo Clinic. And whenever she was prepping the patient with iodine in those old days, if she felt a bump where the belly button is, she knew that they would be inoperable. You only have 6 weeks, not months, 6 weeks to live if you have this. This patient here, you can see, has total disappearance. We have never seen this with the TGen triple, total disappearance of that disease. And not very toxic, not very toxic. Platelets go down a little bit. This is now featured, just to let you know how your work gets disseminated quickly. This is one of the publications in the American Society of Clinical Oncology. Phase 1b/2 study reports high response rates seen with the addition of platinum to the regimen for advanced pancreatic cancer. This is all because of your support, no question. The plan now to leverage that support is treat 100 additional patients with the TGen triple. Celgene has agreed to sponsor that clinical trial. The question is it better than Abraxane plus gem, and will it become the new standard of care? So again, thank you for your important support to discover this new treatment regimen, the TGen triple. Now, since the scar hypothesis, like a physical barrier, seemed pretty good, it's become more complicated, as I said, with the microenvironment. In fact, now pancreas cancer is regarded as the scar or this wound that does not heal. That's the way we're starting to think about it. It's a wound that does not heal. And there's lots of different kinds of cells in that wound. There's the scar cells, which, by the way, now are known as stellate cells. And then there's inflammatory cells, our normal white cells. And there's macrophages, which like to eat things. And there's lots of other special signals. I want to show you how this scar has changed from being a scar that's just sitting there. These are the pancreatic ductal tumor cells, which are not very many. And there's a few stem cells in there, which are the mothers of all of them. And then you have these other cells. And that looks not too bad, but they're communicating with each other. Lots of communications. The question is how do we interrupt these communications so it stops supporting the tumor cells? How do we cut off their supply? Well, as you know, because we did the NABPAC plus GEM, we got the Stand Up to Cancer first grant of $18 million to study the science of this, the basic science. And I know that there are people here tonight, because they're sitting right out here, which we appreciate. The Frank Grange project, we lost Frank. But his work, the work that the team is doing at ISEC has lived on, because they gave us the new big data message to show that these signals are MYC, M-Y-C. So we put that into the Stand Up to Cancer next grant, which was very competitive. And if you can imagine, this is the United Kingdom, okay, which has not had philanthropy for cancer research, giving $8 million to us to work on this signaling. They call it the Transatlantic Dream Team, and here it is. Cambridge University, Bart's Cancer Institute, Princeton, Penn, TGen, Mayo Clinic, Salk Institute, UC San Diego. This all started because of an attack on the scar. And this was very competitive, as Ray and others in the room will tell you, very difficult to get. Here's the team. We just got site visited, looking a little worse for wear. You can see we put the flags out there to keep the peace. We were a little bit worried about Brexit taking away the grant, but they didn't. Okay. Now, the new dream team is that pancreas cancer is a result of a wound healing, and it's a program that's been hacked into. And by using the word hacked, I think the reviewers felt we were modern. This is a wound that will not heal, and what we have to do is reprogram this to heal that wound. And we said, well, you know, is that really possible? But we had convincing evidence. And believe it or not, the first evidence is that vitamin D, which, by the way, 95% of people walking in with pancreas cancer are vitamin D deficient, and I would guess, that except those who are on the lobster boat today, that I'll bet you anything that 75% of people in this room are vitamin D deficient. Just have your internist measure it. What happens when you replace it? You decrease the scar. You decrease the inflammatory cytokine called IL-6. That's bad. You want to decrease it. That's good if you can. It improves perfusion of the tumor. It sensitizes to chemotherapy. And very importantly, this immune environment that this tumor is sitting in, this immune environment has been good for that tumor. It's protected it for all these years. There's nothing wrong with our immune systems out here. It's that these tumor cells have put out for years, do not eat me signals. Do not eat me. Do not eat me. I'm fine down here. And this vitamin D can partially reverse that. Now, I don't know about some of the headlines on this work. This is Healthline News, that this souped up vitamin D does it, but I will tell you that vitamin D can change that scar and heal that scar. High dose. Now, the team at Penn has been testing this in follow-up, and they've taken patients who are surgically resectable and randomized them between the NABPAC GEM, the original one funded by the team here, and added the paracalcitol, which is a very powerful vitamin D, and with or without, and then they do surgery to take out the tumor, and then they give the NABPAC GEM paracalcitol afterwards. For the first time in history in this scar, and this is going to be hard to see, take my word for it a little bit, but for the first time in history, you're starting to get patients' immune system into this scar. You're actually getting, and the people at Penn, when they saw this, said, there's lymphocytes in there. Usually they are not there, and you have no chance of fighting this cancer unless you have your own immune cells in that tumor. It's the scar. Now, you've heard a lot about the immune blockade. These are miracle drugs which actually go in and take out that do not eat me signal. But I will tell you, it worked for Jimmy Carter, right? He had melanoma. But never, never has one of these drugs ever worked for a patient with pancreas cancer. All patients want to take them with pancreas cancer, but it's never worked. So we think that this vitamin D has an opportunity to make this work. And why do we think so? Because here's an example of a patient that was on NABPAC GEM cisplatin. In fact, remember I said there were 2 people up there that they did not respond to it? Guess what? Their vitamin Ds were undetectable. So we actually gave it to a person whose tumor was progressing. And again, it's hard to see, but you can see these 3 metastases, they're down really significantly just after 2 doses of this high-dose vitamin D. So what have we done with this? Well, here's the headline. Thanks to your support, we've tried to take it to the next level. And we actually call this TGen triple. This is now trying the TGen Grand Slam. This is the combination of the triple plus paracalcitol and this anti-PD-1 antibody, the one that Jimmy Carter got in pancreas cancer. And Erkut Borazanci and Gail Jamieson have started this. Again, the budget's for 10 patients. What we're looking for is 60% of people have total disappearance of their disease. First 4 patients have been entered. I can tell you for sure tonight that the last one just went on last week, but the first 3, every single one of them has responded. It's remarkable. Yep. But hoping that keeps going. So, how else can we take advantage of this microenvironment now? Perhaps get rid of these other cells that are in there. These are the macrophages, by the way. In the old days, people used to think these were good. They eat a lot of stuff. They're good. Well, guess what? They're not so good. They actually help support this environment. They support the microenvironment. So we've been looking at these for a while, and so have many, many others, and they say they're good, but now we know they're not good. At the same time, with the Stand Up to Cancer money, Ramesh Ramanathan from the Mayo was working on profiling, because that's what we do at TGen, is profile a patient's tumor, and found that a target was in there called topo1. So because these liposomes, these nanoparticles worked, there was somebody actually up the street here called Merrimack team that put a drug that hits this target into these nanoparticles. They loaded them up. We did a clinical trial. These are patients who had progressed. Their tumor had progressed on Abraxane plus gem. All of them had progressed. And published this in Lancet late last year, and showed for the first time in history that this drug in nanoliposomes actually improved survival even after patients had progressed. The message here is simple. Even if this drug, Abraxane, Gem, Platinum, have failed you, there's still other therapies out there, and we're just beginning. Now, why do we relate this to the microenvironment? Because it turns, by the way, it's 45% improvement in 1-year survivorship. And the FDA approved it in just weeks. Weeks. Now, why do we put this in? Because it turns out these macrophages eat this drug in the nanoparticles. They probably eat the paclitaxel, the Abraxane too. When you have a lot of them, they eat this, and those are the patients who can be helped by this particular drug. What's really interesting is these things eat iron. They eat anything. So you can actually do a scan with intravenous iron, and you can see it lights up white. You can actually see how many macrophages a person has, and you're going to be able to tell whether or not this drug works for them. And what this drug does is it kills those macrophages. It kills them, and they can't support the scar, and they can't support the tumor cells. I want to put these, I did this a couple years ago, Roger, but I've certainly updated the results of the 3 trials now that we have that are so positive. With every other trial that's been done in patients with pancreas cancer from 1990, with more than 800 patients in each trial. And some of these were reported out just a couple of weeks ago. Did they work to improve survival? No, 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 no. Yes, that's our original gemcitabine 5FU many years ago. No, no. No, 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 yes. French regimen called FOLFIRINOX also improves survival. No, 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 no. No, 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 yes. This was the one from Canada, only a 7-day improvement in survival. No, 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 no. No, 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 no. Think of 800 people trying this in each trial. No, yes, the one that I just showed. No, 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 even last week. So only about 9%, almost 10, have ever had a significant effect. I just want to give people an idea in this room who have contributed to this pilot work how important this has been to the field. For our future working together, what's the best direction we can take to make the fastest impact? To keep, and I think it's going to be, let's keep pursuing the SCAR, but let's do it faster. What we need now is a breakthrough approach. We need a breakthrough approach. Rather than doing, we'll do this one, and then we do this one, and then we do this one. You know, it won't be long, and some of us in this room are going to be checking out in the wrong way. This is me here in the nursing home. I'm hoping that's my great-granddaughter, but let's face it, we're all going to be there. She's telling me it's a Coca-Cola, and I can drink it. Who cares, right? I don't even know. So what's the thing we can do together right now to have the greatest impact on the next pancreas cancer? And right now, there are 4 major ideas out there that need to be done as soon as possible on the SCAR. Number 1 is reverse the terrible acidity in the microenvironment. Alkalinize the patient. We can do it with sodium bicarbonate, if you believe it or not. Number 2, you know, you used to think in preventing cancer, you don't want free radicals around, right? So there was a take a little vitamin C, etc. But we want free radicals, because if you have some damage to the tumor cells, they cannot protect themselves. So we want to do super high doses of ascorbic acid. Take out the tumor stem cells. We know they have special pockets in this SCAR. We know how to get them out. Number 4, additional ways to make the microenvironment immunologically unfriendly. We need to make this unfriendly, and I'm going to finish with that in a second. So the solution is this. Instead of testing each idea separately, one after the other, let's do it all at once. One study, all in parallel, answer the 4 most important questions, and get the answer for all of these in 1 year. We could use a special endpoint. Tumor shrinkage is good, but we want total disappearance now. You know, we're pretty hungry. We're shooting for the 60. We want 100%. It doesn't take many patients when you're looking for that kind of difference. None of this small increments anymore. I'd like to call it the bedfern index. That would be bed and furniture index. But I call it the bedfern. And you watch, that'll catch on. Bedfern index. And we really need your help to get this breakthrough funding as soon as possible. Now, I just want to tell you, there are a lot of great new ideas that are coming along. We talked about DNA repair and stem cells, and I could go through here. We're trying to break down this SCAR. We're trying to get into the SCAR. The one that's really the most interesting one is making water smaller. You say, how's that going to help? Well, these SCARs have a lot of water. We can make water smaller, get transferred. So there's actually a thing for the physicists out here tonight. It's called the cosmotropic effect. We like to call it the cosmotropic effect, but the Moses molecule. We actually have a molecule in hand that actually parts the water, and we call it the Moses molecule. We're ready to start with that. But there are some good ideas out there. Now, finally, we haven't forgotten about early detection, because sure, that's the way to cure the disease. We talked about how long it takes to develop. Christine Akabusi-O'Donoghue described this. Probably 21, 23 years. We need a mammogram for pancreas cancer. There are many tools. The number 1 tool, people out on the boat today were talking about screening. Whatever we need, we don't want to use the word screening, because that makes the insurers go crazy, because pancreas cancer is there, but it's not incredibly common. We screen, it would be enormous costs. But identifying high-risk individuals, like we did in Florida together, families, or when you have a relative that's less than 55, or when you have recent onset type 2 diabetes. I know there are people in the room who've had that. Please think of pancreas cancer. So Erkut Borazanci, with your support, has started a clinic like this. We've evaluated 21 families. I can just tell you that we've got Hoag Hospital, Baylor Hospital in Dallas. We're working with Ochsner to try to get these early detection clinics in high-risk individuals. What kind of work are we doing personally? Circulating tumor DNA, we've already published this late last year, that you can detect recurrence 6.5 months early. The best idea comes from the MD Anderson team, exosomes, which you can measure in serum and blood. These are little pieces of the tumor that are given off. Urine. So it's going to be, somebody asked me tonight, how long is it going to be? I think it'll be about 3 years, and we'll be able to say, yes, we're really worried about you having this disease by serum or urine. But then what do you do besides worry? You go through with our current scans and you can't find a darn thing. That is going to be very tough. So I just want to point out, we're working on this personalized imaging, special textural imaging, and very early detection using C13 pyruvate. Stephanie Carlson, who's a great radiologist at the Mayo. So here's textural imaging. You can see we're exploring it with and without treatment, Dr. Ron Korn, but this collects every pixel and is very sensitive, but not sensitive enough. Here's what I want to feature tonight. I was telling Steve this a few minutes ago. This is C13 pyruvate. Remember, these tumor cells they love energy. They feed on everything. That's why people lose so much weight. They are voracious, as every single thing you take in, they eat. Well, this is called a C13 pyruvate MRI spectroscopy, and in mice, I couldn't make the dot small enough. It can detect 0.1 millimeter in a mouse of cancer. It's like a torch. And I'm going to be bold tonight and say, we need your help here. The instrument costs $2.5 million. To make the material takes $2.5 million, but we could do these clinical trials tomorrow. Take a look at that spec. I can't make it small enough to detect it in a mouse. So if we get a positive blood test or a urine test, or if we have somebody who we think is free of disease, and we know where it would come back with this kind of sensitive scan, we have it right now in our reach. We just need to get the instrument. Early detection in high-risk individuals is now being called cancer interception. That's the new term. We talked a little bit about it last year, but cancer interception is the new term for early detection. Now finally, what can we do about prevention? We know the risk factors. It's smoking, diabetes. These cause inflammation of the pancreas, a wound that doesn't heal, pancreatitis. Yes, fizzy, sugary drinks because it developed insulin resistance that these cells need. Well-done barbecued meat, overweight, and the metabolic syndrome are all risk factors. And I'll skip that one. The new clue in the last couple of years is that if a woman with breast cancer, and she has all the therapy, a lumpectomy, radiation, chemotherapy, and said, you're going to be free of disease, if she starts gaining weight, I'm telling you, as docs, we start to cry internally because we know for sure that tumor is going to come back. It's terrible. And these ladies are trying as hard as they can not to gain weight. But we know if they gain 10% of their body weight back, that tumor is coming back and it's going to kill them as sure as we're in this room. So how does that relate to pancreas cancer? Well, if we accomplish this early detection, what can we do? And we can identify these high-risk individuals, but what are we going to do for them? Well, this guy says stay thin, not thirsty, but thin, my friends, because that decreases insulin resistance. But the most remarkable thing is also a lesson from people who are having gastric bypass surgery. Because when they have gastric bypass surgery, their death rate doesn't go down because of cardiovascular. It goes down because of cancer. In the first 3 years, the incidence of cancer, pancreas, breast, colon, goes down by 30%. These things have been growing for all these years, but 30% in 3 years, and no one knows for sure why. But we're very lucky because in the clinic right now, our team is one of 4 that actually has, we call it gastric bypass in a pill. It mimics a gastric bypass, and if this thing is safe, then we'll have something that we can actually give to people who have had breast cancer, pancreas cancer, to try to prevent it from coming back, but even earlier if we see a positive blood test. We could try to start this and see if we can get rid of that positive blood test. This is the most exciting way. Now the question is, what does a gastric bypass do? By the way, it's somewhat of a miracle. If you have type 2 diabetes for 9 years, and they're starting to get eye changes, when they wheel you out of the operating room, 85% of people are cured of their diabetes. 85%. There's no medication that does that. We have no idea, except it probably reverses insulin resistance just like that. So it's very important. What else can you do? The other clue that comes in prevention comes from this big mouse. So if you take a big mouse who's diabetic, and you take the stool from that big mouse and you put it into a lean mouse, the lean mouse gets big really fast. Really fast. They get gigantic quickly by eating the stool of a diabetic mouse. Why? Well, it's really amazing because just in a few weeks, that stool, which contains bacteria, this is what the absorptive capacity of the colon looks like. And this is called the villi. But in just a few weeks, all of a sudden it triples, it quadruples its absorptive surface so that everything that mouse eats goes right into their fat. It's amazing. So we now know there are two types of bacteria. People would call this the microbiome, right? So it's bad, because it's associated with obesity, to have firmicutes. And it sounds bad to me just to have firmicutes, cooties, but and it's interesting because your firmicutes increase the more sugar you eat. It's good to have Bacteroidetes because it's in the lean mouse, they have the Bacteroidetes. And you increase bean consumption, you get more Bacteroidetes. The bottom line in prevention is to stay thin and try to prevent pancreas cancer, but believe it or not, we now have major investigators bringing us, say, here, Dan, try this in high-risk folks who have had all their therapy, and we're just worried it's going to come back. And these are changing the microbiome. These are FDA, going to be certified types of bacteria that actually are going to make sure that you're more towards the Bacteroidetes than you are to the firmicutes. Well, finally, not a part of the talk, but although not a function of our research, Ann and I down there now have 8 grandchildren. We call them the Great 8. Now, we didn't do anything, but Ann's with them all the time. So I'm hoping, one of them turns out to be a doc someday. So I gave Jason a little doctor's kit here, and he was trying it out on his new brother Philip. I don't know if he was trying to give him a lobotomy or whether he was trying to help him, but we sure hope that he's trying to help him. So thanks for the honor of giving this presentation. It's great, and God bless you survivors. It's just great to see you here tonight. And the lesson is we need to continue to pursue the scar. Thank you.